We have learned some tremendous and timely lessons from a 5-year experience working with a risk retention group specializing in bariatric and general surgery care. Timely because of the recent efforts to improve patient safety and quality, and more efforts that are coming our way with accountable care organizations in that regard. Claims which would come in would be analyzed. We would drill down to the exact root cause of the claim, and use the lessons that we've learned from these claims to improve surgical practice. The lessons that we learned from this were extremely important. One of the first lessons we learned was the value of an informed procedure-specific consent, not necessarily just for bariatric surgery procedures, but for all commonly performed general surgery procedures, such as laparoscopic Nissen fundoplication, laparoscopic cholecystectomy, laparoscopic ventral hernia repair, and so on and so forth. We would then apply these lessons to improve quality, to streamline care, and to improve safety practices. Obviously, the commonest claims in bariatric surgery practice revolved around leaks. Even after many years of analysis, discussion, and so on, we still don't quite know why it is that leaks occur. We found when we looked at the claims that in general, patients did not instigate a lawsuit because of the actual leak itself. It's pretty evident from the data that we have that most surgeons will test for a leak intraoperatively. However, that doesn't mean that the patient won't develop a leak 2 or 3 days later. The American Society for Metabolic and Bariatric Surgery has stated that in the vast majority of cases, these leaks are not necessarily due to a technical issue. So it became important for us to explain this on the consent form to the patient, that leaks do occur. It's not necessarily a technical problem that the surgeon has caused at the time of surgery. The commonest reason for surgeons being sued after a leak was failure to recognize the subtle clinical signs of a leak in the immediate postoperative period. And the subtle clinical signs would be a tachycardia, increased oxygen requirement, maybe a slightly increased fever. On a couple of instances, patients were sent home from the hospital with these clinical signs and had a bad outcome later on. So recognition of clinical signs was the first thing. And the second, of course, was timely intervention after a leak. On several different occasions and several different claims, the leak wasn't addressed at the appropriate time, and the patients went on to have intra-abdominal sepsis, and in some cases even death. One of the things that this taught us was the value of an informed procedure-specific consent, not just for bariatric surgery, but for most of the common surgical procedures that we do as general surgeons. Laparoscopic Nissen fundoplication, laparoscopic adjustable gastric band, laparoscopic cholecystectomy, and particularly laparoscopic ventral hernia repairs. Again, laparoscopic ventral hernia repair claims were quite common because of missed injuries. When drilling down with these claims, it helped us evaluate clinical pathways. It also helped us decide and determine that education of staff in terms of the clinical signs occurring after a leak, for example, were paramount. In addition to this, it became evident that we really need to do a better job educating our patients, because leaks do occur when the patient has gone home from the hospital, and the signs and symptoms need to be explained to the patient so they can come back to the emergency room. One other very important facet of all of this is that documentation of everything that occurs around the time of an event, particularly a leak, needs to be absolutely top class. Another fairly common cause for litigation were events that occurred after laparoscopic incisional hernia repair. And the commonest reason for litigation after this was a missed enterotomy at the time of surgery. Again, on a couple of occasions, the patients had gone home from the hospital, called back in with increasing abdominal pain, and the obviously wasn't seen appropriately or treated appropriately and came back in with sepsis. This led us again to examine our procedure-specific consent for laparoscopic ventral hernia repair and document very, very carefully on these procedure-specific consents that missed enterotomy can occur and that problems can occur once the patient's gone home from the hospital in the post-operative period. Something that we often don't pay too much attention to as busy surgeons is the handover of care from one surgeon to the next. For example, if a surgeon is leaving town for the weekend and is handing over his patient list to the surgeon who's coming on duty. On a couple of occasions, we have found that communication between the two surgeons was not adequate to the adverse outcome of some patients. I think these were one of the things that we could have improved upon for patient safety. Another significant reason for claims after laparoscopic or after bariatric surgery was the patient who has...
Just pick up that sentence again. Another after bariatric.
Another common complication after bariatric surgery was the patient with sleep apnea who was not appropriately monitored in the post-operative period. Most patients will have a diagnosis of sleep apnea before they come to the hospital and will bring their CPAP equipment with them. However, some patients have undiagnosed sleep apnea. If they're not carefully monitored in the post-operative period, even after simple procedures like a laparoscopic adjustable gastric band, then they can get in trouble and can suffer from respiratory depression, particularly if they're receiving a lot of narcotic medication. So in general, the lessons that we learned from 5 years of experience with a risk retention group were that in bariatric practice, surgeons will still commonly be sued because of leaks, that leaks are not necessarily a technical problem, that surgeons are inclined to sometimes gloss over the subtle signs of a leak, such as a slightly raised temperature, tachycardia, and sometimes an increased oxygen requirement. Patients don't sue because of the leak itself, but they sue because intervention was not timely and complications occur. Likewise, any patient who calls into the emergency room with, for example, pain after a laparoscopic cholecystectomy or a fever should be seen immediately. Also, patients who call into the emergency room after a laparoscopic adjustable gastric band, complaining of abdominal pain or a fever, should also be seen immediately. And we have discovered over the course of the last several years that complications of the laparoscopic adjustable gastric band are probably underreported. Perforations of the stomach, bleeding from trocar sites, bleeding from short gastric arteries, bleeding from the spleen are occurrences that happen from time to time.